Very good afternoon to everyone who is attending the conference online and offline as well. The topic for today is image-guided tissue sampling. The role of tissue sampling is most important before starting any treatment. So one is to prove the malignancy, second is to guide the staging, third is the treatment planning. The tissue sampling is the most important thing. So there are different types of biopsies which are available. It could be surgical biopsy, it could be endobronchial biopsy with the help of bronchoscopy or EBUS guided biopsy. And a third, which the radiologists are interested is percutaneous biopsy. Percutaneous biopsies could be in the form of either ultrasound guided percutaneous biopsy or CT guided biopsy that I will be coming to the later. And why image guided biopsy is most important. One, it is more precise as compared to just open biopsy. We can technically target the metabolically active area, which is there, as we can see in this diagram, that the medial component is metabolically active and we can target this area accurately. There is less incidence of repeated sampling, and it is safe because it is directly under the vision. So whenever there's any vessel or any bronchus which is coming in the path, we can avoid it by going either superior or inferior or medial or lateral. And coming on to different imaging modalities, one first is ultrasound guided biopsy. This is a conventional ultrasound. If there's a neck node, obviously we can target that much better. Pleural thickening can be targeted with the ultrasound procedure. Whenever it is a mediastinal lymph nodes, it is done generally for staging. Then we can target either with FNAC or FNAB. Depends on case-to-case basis. Third is a fluoroscopy guided biopsy. This is basically to prove metastasis whenever it is there. So when you are doing complex intervention or biopsies in the spine, and it is much better to do it under fluoroscopy because it is real time with combination of CT scan. So another is to confirm the primary diagnosis in case of lung cancer. Under CT scan or a CT fluoroscopy guided, and another is combination therapy with the help of PET CT scan. So the fusion imaging helps where the area is metabolically active. So image guided, the significance is there is high accuracy, there is high sensitivity, high specificity, and in image guided biopsy, the sensitivity is around 82 to 99%, and specificity is 86 to 100%, and accuracy ranges from 64 to 97%. So this is for the malignant lesions. Coming on to the indication of biopsy, why we need to do biopsy. So whenever there is a new lesion, when there is enlarged solitary nodule or a mass which is there, when there are multiple nodules and you can't, so when the patient comes with multiple nodules, to characterize those lesions in case of hilar masses and in case of focal infiltrates. So in case of focal infiltrates, either it could be malignant or benign, okay, but TB being most common, we need to send for culture and sensitivity as well. Whereas in lung cancer, in the era of personalized therapy, the biopsy is most important, where you can study the molecule on those and give a targeted based therapy to the patient, and where the side effects is much lesser. To classify to histopathologically subclassification of these tumor and for the molecular markers. So a contraindication for any image guided biopsy or in image guided tissue is that when the patient is uncooperative, unresponsive, obviously it is very difficult to perform those kind of biopsy. However, can be performed under general anesthesia. When there is positive pressure ventilation, that is the time it is difficult to do biopsy because the pressure inside the lung increases. When there is severe respiratory distress, obviously he can't hold the breath, he can't follow the instructions. So that's why respiratory distress is another thing. Pulmonary hypertension is another thing where there would be bleeding of bleeding can happen profusely, and interstitial lung disease. However, those are most of them are relative contraindication. Coming on to the needle biopsy pre-procedure evaluation. So before starting any biopsy, one need to check the guidelines and check the prerequisite, what is required. So the most important is CBC platelets and platelets above 50,000, coagulation of INR of less than 1.5, 1.5 is required. If patient is on any antiplatelets or anticoagulants, that needs to be stopped. And obviously patient need to be informed about the procedure and the complication associated with it. The most common complication is a pneumothorax, and needs to be counseled regarding a pigtail drainage. If patient is flying abroad, to out of station or his hometown, patient needs to be counseled that after a lung biopsy, you can't fly out, because there would be increase in the barrow pressure, and then the pneumothorax can increase or worsen. So does every lesion require a biopsy or a tissue sampling? So we need to have a CT scan with a contrast for all patients before doing any biopsy. So this was an interesting case which came to Tata Memorial Hospital, and this was a mass which was reported, and obviously right. However, there was no contrast which was available, and after doing contrast, what we found was a pseudoaneurysm which was arising from internal mammary artery after doing a contrast scan. So we need to be careful, and always a CT scan with a contrast is advised. And this was an angiogram which was done, and after going super selectively into the internal mammary artery and coiling that vessel, and thus the bleeding, the patient was not having any mass. So the image guided procedure, the patient positioning is also equally important. So location of the lesion, if the lesion is located posteriorly, as in this case, it is easy to target via prone approach. If the lesion is located in and the anterior aspect, then the supine approach needs to be done. The size of the lesion is also important. Why it is important? Because the smaller the nodule, the chances of it missing is much more there. Another thing, the chances of pneumothorax increases. There is increase in the hemorrhage around the lesion, which can happen, and then ultimately the lesion can disappear. So this can happen once in a while, if you're doing it occasionally. Patient position can be either supine, prone, lateral, decubitus. It depends upon the patient's comfort as well as the operator's comfort. And prone is generally preferred because one, patient can't see the needle, and the anxiety of that patient becomes lesser. The posterior ribs moves less than the anterior ribs, and it decreases the anxiety. So, targeting the lesion, always and always, the peripheral wall, a solid area needs to be targeted, as you can see here, or a central hilar mask needs to be targeted, or a solid enhancing area needs to be targeted. And this was easily targeted, and where we need a PET CT scan. So this is a central hilar lesions which is there. We can go either via the collapsed lung, or posteriorly, as we have gone here, and then we can do the biopsy and target those easily. So as in similarly, if there is a bulla or a cyst which is there, and there is a PET avid lesion which needs to be targeted. So for some of the basic concepts and anatomy, and it is for a CT guided procedure, and that one needs to be take care about the internal mammary vessels which are located on either side of the sternum. Another is a fissures and the pleura, and a third is a rib. So always remember, when we are penetrating, the intercostal vessels and nerves are located inferior to the rib. So always go superior to the rib, or in the intercostal space, and internal mammary vessels, especially for mediastinal lymph node biopsy. Either we can do hydrodissection, we can palpate the sternum and then go into the nodule. So this is how we need to approach rather than from the posterior aspect. So another is a fissures. Always beware about the fissures. Two fissures on the right side and one fissure on the left side, and this needs to be avoided as far as possible. But many times we can't avoid it. So virtually, if we penetrate the fissure, then we will be piercing at least four pleuras. So the parietal visceral of the outer surface and parietal viscera of the inner surface. So we will be penetrating four pleuras, and the chances of pneumothorax increases significantly. So that's why generally when we tell you go from either do a hydrodissection or avoid those things. So fissures are important as seen here. So this is the wrong approach because we have penetrated the fissure, and this is the right approach where we need to avoid it. While doing a CT guided biopsy or tissue sampling, the scan has to be in low kV MA, limited slices. Local anesthesia needs to be given generously. Coaxial technique is always preferable over a single puncture needle because you can take multiple course from that, and the needle length needs to be decided priorly. Either you can take a longer needle or a shorter needle. If there are more bullets, then the smaller gauge needle is preferable. So coming on to the post biopsy care, post biopsy care checks CT scan imaging needs to be done either X-ray or a CT scan. Post biopsy generally recommendation by BGR guidelines is do X-ray chest at 4 hours and then observe it. If it increases more than 20%, then either small bore catheter needs to be inserted, or and there are few cases where there could be delayed complications. So another thing which comes for tissue sampling is endobronchial ultrasound. So this is the technique where the scope is inserted via the trachea into the tracheobronchial tree, and it is done for the lymph nodes around the mediastinum and for the primary mass. So this is how the scope looks like, and this is how the needle enters, and the biopsy or FNAC is taken from the representative area. So coming on to the few indications of EBUS is for staging of mediastinum, where non-small cell lung cancer is suspected, sampling of the mediastinal lymph nodes, diagnosis of unexplained mediastinal lymphadenopathy, and as a research tool for tissue banking and studies for later on. So, what are suspicious lymph nodes on endobronchial ultrasound? One, the classical characteristics like a round shape, a loss of fatty hilum, a heterogeneous ecotexture, a presence of necrosis, and more vessels at the hilum. So, and what's the advantage? So, it is a minimally invasive technique. It is a real time as we are doing it under ultrasound guidance, and which has a high diagnostic yield. It is a safe procedure. It can be done under local anesthesia with mild conscious sedation. And EBUS can target wide range of lymph nodes, right from hilar, 2R, 2L, 3P, 4R, 4L, and so on and so forth, and centrally located pulmonary lesions as well. So, dual benefit, you're doing a staging as well as doing a sampling at the same time. Decrease in, the advantage is it decreases unnecessary thoracotomies and complication. So a limitation, obviously, as ultrasound, it is operator dependent. Cannot target subaortic or prevascular lymph node because they are situated anterior to the vessels, and a lack of availability at all places. And the cores are inferior as compared to the percutaneous biopsy. And it is an aerosol generating procedure. So during the COVID times, you can't do the procedure. But just a few of the examples which I would be seeing here. So in all these are four different cases, all of small cell lung cancer, and what we can see here, the lymph node located around the vessels. Here also it's a similar thing. So paratracheal lymph node or pretracheal lymph nodes. All throughout at 270 degrees, it is located in vicinity of vessel. The percutaneous approach is not possible in all these cases. So what we can do is Since it is located close to bronchus or a trachea, we can do it with EBUS guided procedures or FNACs or a biopsy. So coming on to the last slide and a take-home message, a minimally invasive procedure. So percutaneous biopsies or tissue sampling, it is a minimally invasive procedure. It is very safe and effective in with good accuracy. It is a daycare procedure and can be performed by experienced physician. Thank you. If you have any queries, you can email me or I can answer it. Yeah. So as in today's era, so with the help of with the advent of more and more tissues being required for molecular analysis, percutaneous guided biopsy is much more preferable because the amount of core that you get is highly you can get more amount of cores compared to an EBUS technique. So EBUS either you can get a small core and it is less than 20 gauge needle. With percutaneous you can go up to 18 or 16 gauge needle, and the quality of core is much better with the percutaneous procedure. No, if you see the chances of pneumothorax is almost like less than 20%, and out of which the drainage required is around 5 to 10%. So almost 50% of the so 80% of the patient don't cause any pneumothorax. Even if they cause, they are so negligible that it resolves on its own. It seems like a balloon, and then you are piercing the balloon, but it does not happen anything. Okay, thank you.